Dr. Shilpa Kodkany is practicing in Belgaum. She is the Chief Medical Director of Kodkany Super Speciality Eye Hospital, a very prolific cataract and refractive surgeon. And over to her.
So I'm going to talk about different roles, different goals, that is monovision. Now what exactly is monovision? It is correction of a distance vision in one eye and the near in the other, and the main aim is to correct presbyopia. Now this, more than 3 decades, we've been treating patients with contact lenses and with refractive surgeries and also refractive cataract surgeries for presbyopia. The concept of monovision basically is distance vision correction is done in the dominant eye, near vision correction is done in the non-dominant eye, and we hope that with neuroadaptation the patient will be happy with both distance and near, but in one eye each. Now how do we check for dominance of the eye? It is very simple, very simply done in your OPD itself, where you make the patient look through an opening like this at an object about 10 feet away, and by closing each eye, and the image which shifts is the eye which is non-dominant. That is how you know which is the dominant and which is the non-dominant eye. Now mind you, in patients with advanced cataracts this may be difficult to do. So but still, if the other eye is okay, it's not so advanced, you can still do this test. Now the problems that occurred with monovision were, in the past there was a large amount of anisometropia which occurred, which was, we were aiming at 2 to 2.5 diopters of anisometropia between the dominant and the non-dominant. Stereopsis, contrast sensitivity and binocular vision were obviously compromised, and the most important thing was we were targeting distance and near, but the intermediate, which most of us need today because of our screen times, that was getting affected definitely. And so with the advent of multifocals, trifocals, and now of course EDOFs, we have been able to give intermediate vision also. But with the premium IOLs came certain problems like dysphotopsias, induced aberrations, poor night vision. Some people took time for the neuroadaptation, and there were premium IOLs. Patients are paying so much more, expectations definitely are much more. EDOFs of course do reduce these phenomena, but near vision is not usually satisfactory in them. So mini monovision is what has come in now, and today I have been doing mini monovision for some of my patients, wherein instead of that high degree of anisometropia, you reduce that anisometropia to about 1 to 1.5 diopters. So less anisometropia, faster and better is the neuroadaptation. And since you are using monofocal lenses, as we all know, it's a no-brainer that monofocal lenses are the best for best quality of vision as far as glares and halo goes. So monofocal IOLs also are not as sensitive to the residual astigmatism or to PCOs as compared to the multifocal or trifocals that we use. And they can also be used in borderline corneal and macular pathologies. Now presbyopia correction is the balance of 3 interrelated factors. One is the visual acuity, depth of field, and dysphotopsias. Now visual quality, of course monofocal is the best. Now as far as the depth of field and dysphotopsias go, this is where the game of aberrations comes in. Gold standard monofocal IOLs today have a negative asphericity, and that is so that you get better contrast sensitivity. But having said that, a slight positive aberration is always good for better depth of focus, and that is why for a mini monovision with a normal positive aberration on the cornea, which is usually about +2, then a zero aberration IOL will be a good option to give that better depth of focus. So if you give better depth of focus to these monovision patients, the near vision also will get corrected. So you will be able to give patients distance, intermediate, as well as near in the non-dominant eye. Because then, because of that depth of focus, the patients will see intermediate as well as near. And there have been studies done where zero aberration IOLs have been used, but for this, mind you, we need to pay attention to what the aberrations of the cornea are. There are other studies also done where Finkelman and Barrett have done a study where 96% of patients achieved 20/30 or better distance, 92% achieved J4, good stereopsis and contrast sensitivity were achieved, and in general patients were satisfied with this result. There's another interesting study that has been done by Rocha KM et al., where the aspheric IOL was used in the dominant eye and a spherical IOL was used in the non-dominant eye. And it was seen that intermediate and near vision was better in the eye with the spherical IOL as compared to the aspheric IOL. And the increased depth of field in these eyes were in the eyes which were implanted with the spherical IOLs. And it was such that, like I said earlier, dominant eye had the aspheric and the non-dominant had the spherical IOL. So what we need to aim is best spectacle-free vision is what we can promise our patients as far as monovision goes. So who are the best candidates? Those who already have some amount of anisometropia because they are already used to it, or a pre-existing monovision which they have already got in the form of contact lenses or LASIK. Highly motivated patients for the best spectacle-free vision, and a need for a more cost-effective option. And patients who are into sports definitely will benefit, because especially outdoor sports, the glare and halos are going to be more if you give a multifocal or a trifocal, of course keeping the aberrations in mind. It is definitely not indicated in patients who are drivers, who have the night vision dependency, continuous near work people, professionals like us surgeons, especially people with squints, amblyopias, or who are using prisms in their spectacles. These are definitely not good candidates for monovision. And of course, the retinal pathologies. Counseling, very, very important. Now, very often, I'm sure all of us have seen that monofocal patients whom we do monofocal IOLs in both the eyes, one eye done, it's okay. The second eye, when it is done, the next day, in spite of all the counseling that you do, they will come and say, I could see near yesterday so well before my surgery, and today I can't see near at all. This is usually the case even if you do the best of counseling, even if you have told your counselors, you have done your counseling yourself, and these are all simple monofocal patients. They're not the high-end premium IOL patients, but still we see this. And so we need to explain to the patients very, very carefully when we are doing the monovision. We have to explain about time for neuroadaptation. Both eyes need to be done at least one after the other, and it is always good to do one eye after the other and not simultaneously, because once you do one eye, you know exactly whether you have reached your target, and then you can tweak the other eye a little bit depending upon what your results are for the first eye. Near vision is compromised and will require some correction for fine work or print. This is something that needs to be counseled to all these monovision patients. So what does blended vision? Blended vision is basically we are keeping the patient targeting -1. We are achieving good distance and intermediate, and of course we are able to give near vision with that extended depth of focus that we can give, but it should not be promised. Never over promise. Near vision correction will be required. This is what we tell our patients. If they don't require it, we are very happy, so are they. And what we realize is the same counseling is being done for our EDOF patients. So this is what exactly we tell our EDOF patients. So if we compare, it is the EDOF versus monovision that we would normally be looking at. What is prudent is whether we should be doing an EDOF or a mini monovision in these patients. The criteria, as far as I am concerned, I do it according to affordability and what the patient wants. If the patient is very clear that they want a spectacle-free vision, they cannot afford anything like premium IOLs, then I do mini monovision. And in my hands, the happiest mini monovision patients are the Indian IOL groups. Now, what could be the reason? Is it less expectations? Is it because the Indian options we are using spherical IOLs? Are the expectations more with those who pay more? And of course, today it's not only paying patients. Today, everyone is demanding, and rightly so. The advantages of monovision patients is that they can see distance intermediate, and also in a lot of our patients we see that we can give near vision provided we are taking care of the aberrations. Patients are less dependent on glasses. Night vision of course is better. Contrast sensitivity is better with the aspheric in the dominant eye. The disadvantages, again, like we said, stereopsis to some extent. One eye is used at one time, and neural adaptation can take a little longer in some patients. And of course, we always, in spite of everything, can have some unhappy patients. Now, the take-home messages: mini monovision should be an option in every ophthalmologist's armamentarium. We have to look into the spherical aberrations and the higher order aberrations before planning anything. A mix and match of aspheric and spherical IOLs is always better, and it is a more cost-effective way, and it can be one of your strategies, especially when in your Indian IOL packages. And of course, we need to keep in mind when not to do a monovision. And our strive for high quality and high level of satisfaction continues. Thank you so much.
Thank you, Dr. Shilpa.